Partial meniscectomy is one of the surgeries an aspiring arthroscopic surgeon starts off with. Several times we see that partial meniscectomy is delegated to the least experienced, oftentimes in big units. Actually, inappropriately, inadequately, and improperly done partial meniscectomy can be more detrimental to the knee joint. How do I, oops, what do I do to, it's not moving. The next slide. Sorry? Click the mouse. Thank you. There are two menisci in the knee, we all know, the medial and the lateral. The medial is C-shaped and the lateral is U-shaped. And what do? It absorbs the impact, distributes load, and by its cupping property, it tends to add to the stability of the joint. They are relatively avascular structures, but for the 20% of the periphery of the meniscus, and thereby, there are three zones which we know: the red, which heals predominantly; the red-white zone, most heal; and the white zone, where there is no healing. They are aneural structures as well. So, what is meniscal balancing? When you do a partial meniscectomy, at the end of the procedure, you want to leave a nice rounded meniscus, so that there are no sharp edges, because sharp edges can damage the articular cartilage, causing contralations. The menisci, the medial meniscus in particular, tends to start off with a tear posteriorly, most often in the posterior horn. If it's not dealt with at that stage, it can extend anteriorly, ending up with a longitudinal tear, and this can displace and cause a displaced bucket handle tear. Sometimes the posterior horn tear can end up in a radial tear or a flap tear, and the most often the mechanism is a twisting injury or a blow to the side of the knee, where the meniscus is livered and you can end up with a radial tear. There's a flap tear which, left unattended, can cause contralations, and a posterior horn tear can end up with a complex posterior horn tear too. Yet another example of a meniscal tear with and without chondral lesions. So, to do a good partial meniscectomy and balance the ligament, balance the meniscus properly, you need good tunicate, a stable thigh support, wherein you can actually lever out the knee to about 45 degrees. In tight knees and posteromedial corners, a pump most often helps. And these are the three instruments which I feel is very helpful to do a good partial meniscectomy. Angled cigar handle punch, you will see that in the next slide how it's used, and angled scissors and loop handle punches. And these have to be really low profile instruments, so that your damage to the articular cartilage is kept to the minimum. This is a longitudinal tear, chronic tear of the medial meniscus. That is the angled cigar punch, and you do not approach the meniscus 90 degrees to the tear of the anterior axilla. You actually start off at the normal meniscus at an angle of 10 to 20 degrees, then you delve into the normal meniscus and you reach the anterior axilla. Once you've done that, you can use a angled scissors to kind of release the anterior attachments, release the meniscus, and subsequently you approach the posterior axilla at a 30-degree angle. Then you can remove the rest of the meniscus either with a grasper, twist it and turn it, or you can just put a shaver and remove the meniscus. So by the time you finish, you have a nice rounded edge. Yet another example, is that's a tear in the white zone. You should also be prepared to swap portals. Yet again, the angled cigar punch. You start off for about 10-20 degrees. Then as you can see, you can barely see the anterior end of the tear just below the femoral condyle there. When you get near that, you probably can swap portals and come in with a low profile punch and access it at an angle of 30 degrees so that you end up at the anterior angle of the tear. Once you've done that, you can take the angled scissors and go around the tear from front to back, release whatever attachment is there. This, if done appropriately, you can end up with a good balanced meniscus rather than taking the duckbill and going in at 90 degrees and chopping the meniscus off in bits and pieces, leaving with a lot of dog ears. So you suck and remove all the debris, then you put a grasper and you can literally turn the rest of the meniscus and take it out. And by using this low profile instruments, you can really keep the scuffing and the scoring to a real minimum. Once you've done that, you go back in with a small shaver and just smoothen the rough edges. You need to make your portals right to be able to access the anterior and the posterior axilla. You should be prepared to swap portals to get the meniscus in toto, appropriate and adequate instrumentation to keep the scuffing and scoring to the minimum. Thank you very much.